Okay, in the previous voiceover PowerPoint, we wrapped up talking about the ECG pattern and how that related to the cardiac conduction system. We're ready to talk next about how the cardiac cycle and the conduction pathways and system are regulated by our body. And this particular slide you see in front of you should look familiar. We've talked about this many times. The fact that often receptors pick up changes that take place within the body, that they relay nerve impulses via sensory or afferent neurons to the central nervous system, which is the brain and spinal cord oftentimes, right? In this case, it always is brain and spinal cord. And then from there, that information is sort of compared and analyzed by the brain and spinal cord, and then impulses are sent out motor or efferent neurons to some sort of an effector which responds in some way. In this case, of course, the effector will often be the heart, because we're talking about the cardiac cycle here, aren't we? Although, as you'll see in this voiceover, there can be other effectors besides the heart that can impact the heart's function. So here we're looking, of course, at the heart on the right-hand side. You should recognize many of the anatomical features associated with that diagram. We're also depicting some major blood vessels that are branching off of the aorta here. These are the carotid arteries. We'll talk more about specific types of receptors found there, but you can see here in the upper corner of the diagram, we're specifically mentioning what are called baroreceptors or stretch receptors, and they're also found actually down here in the aorta. So more on those particular receptors and the role they play a little bit later. But on the left-hand side of the diagram, of course, is a frontal section, I should say, not a cross section, but a frontal section of the cerebrum, the brain, below which is a cross section or transverse section of the spinal cord here. These are just sectional views as we proceed down the cord. This, of course, is actually part of the brain stem, so it's technically not spinal cord yet. It's part of the brain, but down here we have definite cord cross sections. And you can see the gray matter here in the middle, making this sort of swallowtail butterfly sort of shape, and then the white matter around it. You'll be talking, of course, more about the nervous system in A&P2. And what we're looking at here, what we want to focus on here, is the fact that we have emanating from the brain stem, shown here in blue, from the medulla of the brain stem, are efferent motor nerve fibers that are traveling from the brain stem here toward the heart. And specifically, these efferent fibers have a name. These are parasympathetic fibers within what are called the vagus nerves. You'll be hearing more about vagus nerves coming up in A&P2. They're very, very important in lots of different ways. But one important role they play here is in actually slowing the heart down. And the way they do that is when impulses arise here in the brainstem and are carried to the heart, so these are motor or efferent fibers, they will release at their terminal ends here a neurotransmitter you have all heard of before. It's called ACH, acetylcholine. Where have we heard about that? Well, that was back at the neuromuscular junction. Remember, we discussed that in one of the previous chapters. This neurotransmitter is also released here at both the AV and SA nodes. So here's the AV node here. Here's the SA node in the upper portion of the right atrium. We talked about that in the previous voiceover, so you should know what those do. And so when acetylcholine is released at those nodes, when impulses are sent down those vagus nerves, that actually slows the heart rate down. It slows the pace of the heart. There are less frequent impulses being sent to the heart. The result is the rate slows. Okay, so these are really important motor impulses, part of what's called the parasympathetic branch of the autonomic nervous system. And so associate, for now, parasympathetic with vagus nerves and slowing the heart. Okay? Set of nerves that branch off of the spinal cord are shown here in blue. Okay, so we've got now impulses arising from the spinal cord being sent to different parts of the heart. You can see here that this particular nerve is referred to as an accelerator nerve. Actually, there's a pair of them, accelerator nerves. And these accelerator nerves will synapse at various locations within the heart. So like the vagus nerves, we see some of those branches of the accelerator nerves ending on the SA node, some ending on the AV node, some ending here in the top of the interventricular septum, the bundle of His, and others branching to the Purkinje fibers here within the myocardium. Unlike the parasympathetic vagus nerves, which released acetylcholine and slowed the heart down, as you can see here, when impulses are sent down the accelerator nerves, which we associate with the sympathetic branch of the autonomic nervous system, a different neurotransmitter is released called norepinephrine, sometimes also referred to as noradrenaline. It's a close cousin of epinephrine or adrenaline. And so when impulses are sent down these accelerator nerves and norepinephrine is released at these various locations, this acts to speed the heart up. And as the name implies, accelerator, speeding up the heart. Okay? We often associate these with the fight or flight response that we talked about in the Zoom meeting on Monday. Okay. Let's go back to the medulla and note the presence of the cardiac control center here within the medulla. So as the name implies, it's here that sensory information is going to be taken and analyzed, and from the cardiac conduction system, or center I should say, will emanate impulses associated with the vagus nerves. They would actually come from what is referred to as the cardioinhibitory reflex center, or cardioinhibitor reflex center, same thing. And there may also be impulses that emanate from another part of the control center here, referred to as the cardioaccelerator reflex center. And they're going to send impulses down these accelerator nerves to speed the heart up. So just as the name implies, cardioinhibitor, slowing heart rate down, cardioaccelerator reflex centers, when they send impulses to the heart, will speed the heart up. And so these two components of the cardiac control center of the medulla, what they're doing is they are monitoring information coming from sensory data. Okay? So there's impulses that come from the heart itself that impact the heart itself. It's kind of weird. You got to think about this a little bit. So let's talk about a couple different receptors, which we actually referred to not too long ago when we started this voiceover. I want you to look now up here in the major branches coming off of the aorta. These are the carotid arteries, right and left. And within the walls of the carotid arteries, we have special baroreceptors or stretch receptors. They're monitoring the stretch of the blood vessel as blood is forced through it. Also, in the aorta are some additional pressure receptors, baroreceptors, stretch receptors. They're all the same thing. They're monitoring the stretching of the wall of the aorta here, just like the baroreceptors up here in the carotid sinus. We're monitoring the stretch of the walls of the carotid arteries. Now remember, blood's being ejected from the left ventricle through the aortic semilunar valve into the aorta, so blood is under high pressure here. It's also under high pressure up here in the carotid arteries. So if they detect elevated pressure or even a drop in pressure, they will send sensory impulses back to the cardiac control center, and the heart can then adjust accordingly by either speeding the heart up, by stimulating the cardioaccelerator reflex center, which in turn sends signals down the accelerator nerves, which speeds the heart up, or maybe if we need to slow the heart down, we would stimulate the cardioinhibitory reflex center, which would set impulses down the vagus nerves, which would in turn slow the heart rate down. Because in this particular example of homeostasis, we want to maintain a fairly constant heart rate, which of course then also impacts blood pressure. Watch a video.
Increased blood pressure stretches the carotid arteries and aorta, causing the baroreceptors to increase their basal rate of action potential generation. Action potentials are conducted by the glossopharyngeal and vagus nerves to the cardioregulatory and vasomotor centers in the medulla oblongata. As a result of increased stimulation from the baroreceptors, the cardioregulatory center increases parasympathetic stimulation to the heart, which decreases the heart rate. Also, as a result of the increased stimulation from the baroreceptors, the cardiovascular center decreases sympathetic stimulation to the heart, which decreases heart rate and stroke volume. The vasomotor center decreases sympathetic stimulation to blood vessels, causing vasodilation. The vasodilation, along with the decreased heart rate and decreased stroke volume, bring the elevated blood pressure back toward normal. If the initial problem were a decrease in blood pressure, the activities and effects of the baroreceptors, cardiovascular center, and vasomotor center would be the opposite of what is illustrated.
Okay, I would suggest you watch that video several times because seeing it once is a little confusing. But go back, watch it a couple times, focusing again on how this system maintains proper heart rate, and as we'll talk about in an upcoming voiceover, proper blood pressure. Now you might have noticed that in addition to impulses being sent to the heart to either speed it up or slow it down, which in this case was to slow it down because there was an elevation in the blood pressure, so the baroreceptors were stimulated, weren't they, up in the carotid sinus and in the aortic arch. And those were sending impulses back to the cardioinhibitory reflex center, which in turn slowed the heart rate down, remember? It also talked about in the video how the smooth muscle in blood vessels could also be impacted by blood pressure in the aorta and in the carotid sinus. And we're going to talk more about what's called the vasomotor center coming up in a few minutes. But do not confuse the vasomotor center with the cardiac control center. The cardiac control center controls the heart. The vasomotor center will regulate the lumen or diameter of the blood vessels by impacting the smooth muscle which lines the blood vessels. Okay, so in addition to blood pressure changes, for example, in the aorta or in the carotid sinuses of the carotid arteries, there are other factors that can also influence whether the heart rate speeds up or the heart rate slows down. So let's talk about a few of which we've all experienced. For example, when we run a fever, our body temperature can have big impacts on the heart. Generally, as body temperature goes up, and again, think about, for example, when you get a fever, that's a good way to think of it. That actually results in an elevation in heart rate. In the same way, if the body temperature falls, the heart rate would slow down. And prior to modern cardiac surgery, one thing that they tried to do back in the 50s is they actually immersed patients in an ice water bath in the surgical room to slow the heart down in an effort to do some very rudimentary surgery on the heart. But because we're not hibernators, it didn't work very well. You know, some animals like woodchucks, let's say, actually go into hibernation in the wintertime and their heart rate slows really, really, really slow. We don't work quite the same way physiologically, so it wasn't a very effective way at surgery of the heart. You couldn't lower the body temperature too low, or otherwise you'd kill the patient. But if you look back in the history books, you'd actually read about times when they actually tried this before they could adopt heart-lung machines to take over the control of the blood pressure for the patient. Potassium, this is an ion, as evidenced by the positive charge. K, of course, represents the abbreviation for potassium on the periodic chart. Potassium has a really big role to play in impacting the heart, because if we have an excessive amount of potassium, it ultimately affects impulse conduction in the heart, whereby the heart contractions are significantly reduced, as are the force of those contractions of the ventricles, for example, if too much potassium is present in the body. We refer to that disorder as hyperkalemia, hyper meaning elevated, right? Elevated. Hyperkalemia refers to potassium. If you were to inject somebody with an excessive amount of potassium suddenly into their bloodstream, you could actually stop the heart in its tracks. And that's what the second part of this kind of refers to. It would completely block conduction of the impulses that are part of that cardiac conduction pathway. Yeah. And I believe some of the drugs that they use within the death penalty, when they're death by injection, one of those injections is a massive injection of potassium to stop the heart of the person. Calcium, we've talked about quite a bit throughout the last 3 or 4 months. Here is yet another example of the role that calcium can play as it impacts the heart. And just like too much potassium was problematic, too much calcium in the hypercalcemia situation, if a person finds themselves into, can result in prolonged contraction of the heart, and actually can be an issue if too much calcium is present. So we always talk about blood calcium regulation, right? To maintain proper muscle contraction, proper bone matrix strength, and that kind of thing. Well, again, if we have too much of it, or even if we have too little of it, hypocalcemia can have direct impacts on the heart. We're going to turn our attention next to blood vessels. This is section 15.3 in your book on page 576. We're going to take a look first at an artery, which you know is defined as a blood vessel that carries blood away from the heart. And here we see both a sectional, longitudinal sectional view here, and a cross-sectional cut, transverse cut of the blood vessel. And we note the lumen here in the very center, where the blood, of course, is being carried. This is the endothelium. Okay, it's part of what's called the tunica interna. It's the deepest layer of this blood vessel, tunica interna, composed of simple squamous. You can see those cells here, of course, here in pink. Flattened cells. You remember squamous from earlier in the semester. One layer thick, simple. And then just out from the tunica interna, just out from the endothelium of the artery, is a fairly thin layer of connective tissue. Notice it says rich in elastic and collagenous fibers. So it is strong, but it's also elastic. It has to be able to withstand the pressure of the blood, which is typically higher in most arteries. Outward from the tunica interna is the middle tunica media, making up the majority of the wall of the artery. And notice here we have primarily smooth muscle, as evidenced by the red coloration here. Smooth muscle. But also notice it indicates the presence also of a lot of elastic connective tissue. So we had a little bit of it just in from, or just out from the tunica interna, this gray region, but we also have it infiltrating the tunica media. And again, that's really important because blood being ejected or carried by an artery is generally carried under higher pressure. So to accommodate that pressure, we have a lot of those fibers, those elastic connective tissue fibers, to accommodate that increased pressure. Finally, the external-most layer of the artery, the tunica externa. This is not terribly thick. We do have some continued elastic fibers present, but we also have collagenous fibers, which again, you know, are strong. And this layer is really there mostly to help attach the artery to surrounding tissues. Kind of stabilizes the structure of the artery. Okay, this is going to relate back to the video that we looked at about 10 minutes ago, which I want you to go back and watch that again after we talk about this. I made mention at that time of how the vasomotor center, which is again separate from the cardiac control center, they're both housed in the medulla or medulla. The cardiac control center impacts the heart. The vasomotor center, which is also receiving sensory information from receptors, baroreceptors, okay, like the cardiac conduction system or cardiac conduction, cardiac center, I should say, is receiving stretch data from blood vessels. So too does the vasomotor center receive sensory information. But when it gets stimulated, it's going to send impulses, sympathetic impulses. Remember, these, when sent to the heart, sped the heart up. Well, when we send sympathetic impulses to the smooth muscle, and that's what the vasomotor center does, it's impacting smooth muscle, does not affect the heart. It's going to cause the smooth muscle to contract. And when you have vasoconstriction of the smooth muscle in the tunica media, the result is that the lumen gets smaller. And if the lumen gets smaller, that's going to result in greater blood pressure through that lumen, through that artery. Now, if we were to inhibit those sympathetic impulses, okay, leave up on the accelerator, if you will, that's going to slow blood flow in the blood vessel. How does that happen? Well, instead of having constriction, if we inhibit those sympathetic impulses, that's going to cause relaxation of the smooth muscle and induce what's called vasodilation. Now, look at this word. It's not vasodilation. A lot of people mispronounce it. It's vasodilation. So vasodilation occurs when smooth muscle in the tunica media relaxes. That causes the lumen to get larger. If the lumen gets larger, that will reduce blood pressure. So the vasomotor center is again constantly regulating the lumen of blood vessels like the artery here by either stimulating the smooth muscle or relaxing the smooth muscle. As we go from the artery a little bit more distant, we encounter another blood vessel called the arterial. This is a smaller diameter blood vessel. I want you to note that there is no real middle tunica media here like we had in the previous diagram, nor tunica externa. We have a tunica interna, as evidenced by the simple squamous cells here in kind of orange. So the blood is passing through the lumen. We again have a lumen here, right? Just like we do in every blood vessel. That's the space through which the blood is being carried. But I want you to also pay attention to the fact that we do have smooth muscle fibers that wrap around the arterial, only they are not layered like we had in the tunica media earlier. We had a thick layer of smooth muscle. Here we have individual smooth muscle cells that wrap around the simple squamous of the endothelium. What do you think those smooth muscle cells are there for? Well, if there's a need to increase blood pressure through this artery, or to even reduce blood pressure in this artery, we can stimulate those smooth muscle fibers or relax those smooth muscle fibers, right? And that's what the vasomotor center is going to do. Back to our vasomotor center. So the vasomotor center can stimulate these smooth muscles, causing vasoconstriction, or can cause these smooth muscle cells to relax, causing vasodilation. And that has a direct impact on blood flow into capillary beds, because that's our next blood vessel that we're going to talk about. So we had arteries forming arterioles, and arterioles now transitioning into capillaries. And here we see some capillaries here. Note the color. Typically, arteries carry oxygen-rich blood. Veins typically carry oxygen-poor blood. The exception to the rule are the pulmonary veins and pulmonary arteries. Okay, we talked about that earlier. But all arteries, except for pulmonary arteries, are carrying oxygen-rich blood, and most all veins, except for pulmonary veins, are carrying oxygen-poor blood. So that transition between oxygen-rich and oxygen-poor are the capillaries. And this is where that gas exchange occurs if we were, for example, in the lungs, or if we're in the systemic circuit. It's here that nutrients are exchanged for waste products, right? So we see that transition from red into sort of a purple and then into blue. Also note here that we have special rings of smooth muscle fibers here just before the capillaries, called pre-capillary sphincters. And so these can have direct impacts on how much blood passes into capillary beds. If these sphincters are stimulated to constrict, that's going to reduce blood flow into capillary beds. If these smooth muscle fibers are not stimulated, they will relax, and we will be promoting blood flow into those capillary beds. The other interesting thing to note in this diagram are the remaining two blood vessels we need to talk about. So we've talked about arteries, we've talked about arterioles, we just finished up talking about capillaries. Here are the two remaining blood vessels. These are the venules and then veins. So there's the four: artery, arterial, capillary, venule, vein. That's the sequence that blood passes through when it leaves the heart. Okay, turning our attention to the vein, and let's kind of compare it to the artery, even though we don't have the two side by side, but you can check out page 577 of your book where they do compare and contrast the artery with the vein. What are some of the similarities? What are some of the differences? Well, one difference that you should note immediately is the much larger lumen here in the vein compared to the lumen of the artery. Much, much bigger area for the blood as it passes through an artery or through a vein. The other thing that I want you to note is the presence of valves here that come off of the endothelium, which is again simple squamous. So the valves are unique to veins. Arteries don't have valves. And this is going to have a role to play in helping to promote blood flow in one direction. In this case, it's going to be upward. So we've got, again, the tunica interna, made up of the endothelium, as we just mentioned a moment ago. So that's common to the artery as well. We have a tunica media. But what makes the tunica media of the vein different from the tunica media of the artery? That should be very obvious to you. We have a much thinner tunica media here, don't we? Not as much in the way of smooth muscle, although there is smooth muscle here. I'm not saying there's not, but not nearly as thick a layer of smooth muscle. And also, as a result of a thinner tunica media, less elastic fibers. Now, I don't want to say there's no elastic fibers here in the veins. There are. As you can see here, they do mention elastic and collagenous fibers in this sort of in-between region between the tunica interna and tunica media. So there is collagenous fibers, there are elastic fibers, but they're just not nearly as abundant here in the tunica media of the vein as they were in the artery. And why do you think that is? Well, it has to do with blood pressure. There's not nearly as much blood pressure occurring in veins as there are in arteries, and that's why you don't have nearly the amount of elastic tissue in the tunica media of a vein as you do in the tunica media of an artery. And finally, the tunica externa there for mostly attachment of the vein to surrounding tissues. That's really what it's for. There are also some elastic and collagenous fibers in the tunica externa as well. This is an interesting comparison between a cross-sectional cut through a venule and a cross-sectional cut through an arterial. And one thing that should be obvious to you is the fact that the venule, which remember is coming off of the capillary bed leading to the vein, the diameter here of the lumen is a lot larger, isn't it? And that doesn't surprise us because just like we mentioned a moment ago, the corresponding vein lumen was a lot larger than the lumen of the artery. So the venule also has a larger lumen than the arterial. These little black dots that you see here in both of these diagrams, these really tiny little guys, these are RBCs. All those little structures are red blood cells. What else do we notice here in terms of a difference? Well, let's look in the wall of these two blood vessels. Which has a thicker tunica media? Well, the arterial does here, right? Yeah, it has a much thicker tunica media than does the venule. Now, does the venule have a tunica media? Yes, it does. It has smooth muscle and elastic fibers, but it's not nearly as thick. Why is that? Because the blood is being pumped under less pressure here by the time it gets to the venule than when it branches off an artery. Well, we said a moment ago that veins were very interesting in the fact that they have valves, right, coming off the tunica interna. And this is depicting, of course, blood passing through the vein. In this case, it happens to be moving upward. So let's pretend this is a vein in your leg, with the heart, of course, above your leg. And so when blood passes through a vein, the valve opens up, and then to prevent any backflow of blood, the valve closes, as we see in the right-hand diagram. Sort of pools there a little bit. And then it may, again, If the pressure on this side of the valve is higher than the pressure on this side, the valve's going to open up and blood's going to head toward our heart. If the pressure on the top here, if you will, is higher than the pressure below the valve, these valves snap shut. So again, just like with the heart valves, valves and veins open and close depending upon pressure differences across the valve. It's simple physics. Now we're going to talk a little bit later about what forces blood through veins. You might be thinking, well, the heart, of course, as it pumps, pushes blood through veins. Well, you might be surprised. Not necessarily the case. I'm not going to play this video, but I do want you to watch it. It's a very interesting video that talks about how people can have injections to actually dissolve varicose veins. Varicose veins occur when the lumen and the entire wall, actually, not just the tunica interna, but the entire 3 layers of the vein get larger, and the vein bulges out, right? So somebody, let's say, who is pregnant often suffers from varicose veins as the pregnancy, elapses. Somebody who's standing on their feet a lot, if they're working at a store, that can lead to varicose vein formation. And so they're sort of unsightly, if you will. And so one way to get rid of them is through this injection procedure that this video will show you. Very, very interesting. Let's take a look at where our blood is in our body. If you take a look at all of the various structures shown here at the bottom of the diagram. So we've got lungs, we've got the heart, we've got systemic veins, we've got systemic arteries, and we have capillaries. So we have 3 of the 5 major blood vessels. We're not looking at venules or arterioles here. We're looking at the big guys. The veins, capillaries, arteries. You'll note that the vast majority of blood in your body at this very moment lie in the large veins and in small veins, and actually here's venules. We didn't see that. In fact, a lot of the blood are in the small veins and small venules. So, 65% of the blood in your body are in the veins and venules. That's very interesting. Followed next by the lungs and systemic arteries. And then sort of in third place comes the heart, and in last place comes capillaries. So most of your blood are in your veins and venules. Interesting. But this doesn't surprise us, because when we talk about the veins being important as blood reservoirs, now that makes perfect sense. So if you're, for example, starting to bleed for whatever reason, you have an injury, your body will tap into the veins to try to negate that blood loss, to try to maintain your blood pressure. Speaking of blood pressure, let's talk a little bit about that. Had we met in lab, we would be measuring our blood pressures with a device called a sphygmomanometer and a stethoscope. But I think you've all had your blood pressure taken at some point or another in your life. This is the force of the blood as it's exerted on the inner tunica interna of blood vessels. We typically measure blood pressure in arteries, but you could measure blood pressure in veins too, for that matter, venules or even arterials or capillary pressures. If you had the proper instruments, you can even measure that. But when you get your blood pressure measured at the store, if you go to, say, a pharmacy and you use the automatic thing, you put your arm in, push a button, and the cuff goes down automatically, and then it releases the pressure automatically. Or whether you go to the doctor's office and the nurse takes your pressure, they are measuring actually left ventricular pressure. They're measuring it in arteries that are branching off from the aorta. Here's the setup. Here's the device that I was referring to a few moments ago. This is referred to as a sphygmomanometer. Sphygmomanometer, funny name. Here's the blood pressure cuff. It's wrapped around your arm, of course. There's typically a dial that's measuring the pressures. So as you inflate this bulb after closing off the air control valve. As you pump that up, this is going to inflate the cuff, and you're going to see this needle begin to move to higher values. And when you measure blood pressure, you measure it in millimeters of mercury, mmHg. That's the unit, millimeters of mercury. And so typically when you take a person's blood pressure, you would again wrap it around the arm, you'd close the valve, you'd pump it up. Generally you want to go, I would say, to at least 140 millimeters of mercury, because what that's going to do is it's going to close off the lumen of the brachial artery. That's what you're measuring the blood pressure with, the brachial artery it's called, B-R-A-C-H-I-A-L, brachial artery. And you're going to put a little stethoscope diaphragm right over the brachial artery, right about where I've colored this in blue. So this is connected to the stethoscope. And you'll pump that up to about 140 millimeters of mercury. That's going to close down or clamp down on that brachial artery, so no blood passes through it. So when you listen with the stethoscope, you're not going to hear any noise because there's complete closure of the brachial artery. Then what you're going to do is you're going to very, very carefully and slowly relieve the pressure here by opening that control valve just a little bit. And you're going to watch what happens to the pressure. You'll watch the dial, and you'll see the pressure begin to fall from 140 down to 130 to 120 and so on. And as you're listening now for the blood that's going to start to come through that brachial artery, as you release the pressure on that occluded blood vessel, you'll start to hear some sounds. And those particular sounds that you're listening for, they're called Krotokoff sounds. And those sounds will get louder as more and more blood begins to spurt through that opening, I should say, of the brachial artery. You don't open it up all the way. You open it up a little by little. So when you first hear that sound of the blood coursing through the brachial artery, you make note of that number. That's the systolic pressure. And generally for a healthy individual, that's typically about 120 millimeters of mercury. Okay, so you first start to hear that sound. You make note of that. That's the systolic pressure. That's this number. And then as you slowly let more and more air out, the dial's going to continue to drop more and more. The sound may actually get a little louder. The little needle here may begin to start to bounce around a bit too. And eventually, as you continue to bleed the air out, the sound will disappear because you will have opened up that lumen completely. No more pressure on it. You won't hear any more heart sounds or any more Krotokoff sounds. And that particular number where you last hear the sounds, that's the diastolic pressure. And again, for the average individual, average adult, is somewhere around 80 millimeters of mercury. Although I think this fraction, they may be changing the expected normal values. I think I read something recently, the American Heart Association is kind of revisiting that, but we're going to go with 120 over 80 for now. So again, 120 is the systolic pressure, 80 is called the diastolic pressure. So that's what we would have done had we met in lab. We would have measured each other's blood pressure using a sphygmomanometer and a stethoscope. And a lot of you guys are really good at doing this because you do it every day at work. This last slide is really, really interesting. And what we're looking at here is the blood pressure. And you can see, of course, systolic here over diastolic. And there's the 120 over 80. That would be typical of major arteries like the brachial artery coming off of the aorta. As we follow the pathway of blood from the aorta here, eventually blood's going to be taken into larger arteries like the brachial artery, and then eventually into smaller arteries, and eventually to the arterioles, and eventually to the capillaries where we have gas exchange and waste product nutrient exchange. And then again, eventually, ultimately to the venules, and then smaller veins and large veins. And we make our way finally back to the inferior and superior vena cavae before we eventually get back to the heart, right? and then we start the whole process all over again, look at what happens to the pressure of the blood as it leaves the heart, heads to the capillaries. Wow, there is a precipitous drop, isn't there, in the systolic and the diastolic pressures as we get further and further away from the aorta. By the time we get to capillaries, these, remember, very small diameter blood vessels, so small that blood cells squeeze through in single file, right? Those red cells, those white cells, even the platelets, they're moving through in single file, especially the red cells, I guess. The platelets, being so small, may go through much, more numerous than one at a time. But the red cells, remember, are carrying the oxygen. The hemoglobin is. So we go from 120/80 leaving the heart down to, basically the systolic and diastolic pressures almost become one of the same, although there's a little bit higher systolic than diastolic here. But we're down to 25 or 30 millimeters of mercury. It's a fraction of what it was way up here when we left the heart. So blood is passing through at a much slower rate, slower speed. And that's good because you want gas exchange to occur. You want nutrient waste product exchange to occur. You want to have that happen optimally, and it's best to have it occur if the blood cells are moving through one at a time rather slowly, right? We will talk a little bit later in one of the upcoming voiceovers about the force of getting the blood from this particular point in time through the venules, through the large and small veins, and then eventually back to the vena cava. So that's coming up on a future PowerPoint.